Hi, my name is Caitlin Russo, and I'm a developmental and behavioral pediatrician at Vanderbilt University. I'm excited to talk to you today about our study titled Evidence for Pharmacogenomic Effects on Risperidone Outcomes in Pediatrics on behalf of my co-authors. This study examined the medication risperidone, which is commonly prescribed for a variety of pediatric indications. Some include on-label indications, such as using it for irritability associated with autism, but it's also frequently prescribed for a variety of pediatric behavioral concerns that are considered off-label. While taking this medication, up to 1 in 3 children experience an adverse event, and these can include significant adverse events such as things like weight gain and metabolic abnormalities. There are multiple pharmacogenomic panels that include various genes to help guide risperidone dosing. Unfortunately, a lot of the genes included on these panels include really limited prior pediatric data. Thus, the objective in our study was to determine the association between multiple different genetic variants and the risk for pediatric risperidone adverse events. We looked at 9 different genes of interest on this study, and all of these genes are involved either in the metabolism of risperidone or have something to do with the effect that risperidone has to do on the body. This was a retrospective cohort study. We included children who were less than age 18 at the time of starting risperidone, who were on the medication for 28 days, and whose prescription was managed by a Vanderbilt provider, as well as children who had DNA available in BioView, Vanderbilt's DNA biobank, which speaks to the innovation of this study. Our exposure was genotype, and our outcome was adverse event as determined by manual chart review. For analysis, we first did a univariate analysis where we looked at each gene individually. Then we did a multivariable logistic regression model where we included each gene as well as covariates of interest, including age, race, sex, and dose. We then did a third multivariable model where we included any genes of interest as well as our covariates together in a final comprehensive model. This shows the demographics of our study cohort, and as you can see, we had 257 children, which speaks to the significance of this study. For many of the genes of interest, this is the largest study to date in a pediatric population. Our cohort was largely male, white, non-Hispanic, and included indications such as aggression and behavioral concerns for diagnoses such as ADHD and autism. This table lists all the different genes and variants examined in this study, and the 2 highlighted in red are the only 2 that showed any significance with respect to pediatric risperidone adverse events. The first is CYP2D6 or cytochrome P450 2D6. The second is HTR2A or serotonin receptor 2A, and the specific variant RS6311. As you can see, none of the other genes examined in this study showed any significance. Thus, we included these 2 final genes in our final multivariable logistic regression model. And as you can see, those children with poor or intermediate CYP2D6 metabolism experienced more adverse events compared to normal, rapid, or ultra-rapid metabolizers, as well as those children with HTR2A RS6311 variant who had more of those variants experienced fewer risperidone adverse events. There are important limitations of this study, as with all studies. First, we couldn't identify medication adherence in our data source. Secondly, this study was retrospective in nature, which prohibits us from determining causality. Considering our data and prior pediatric data, these are suggested clinical applications for our study. First, if you have a child who you know has reduced CYP2D6 metabolism, you could consider alternative medications to risperidone, and if using risperidone, you can consider reduced dosing or increased monitoring for side effects. Due to limited prior pediatric data, we do not recommend changing clinical practice based on the known variants of HTR2A in pediatric patients at this time, although we suggest that further research is needed. And importantly, most of the genes in this study did not show any significance with respect to risperidone adverse events. Thus, we do not feel like there is sufficient data to alter pediatric risperidone dosing based on these genes at this time. Thus, clearly, future work is needed in this area, hopefully with larger sample sizes.